My topic given to me is transplantation and clinical ethics. He covered extensively about ethics related in research. You may be fully saturated with this particular keyword: ethics, bioethics, ethics, clinical ethics, research ethics. So I need not go into the exact definition. There can be many definitions, and what we have to know is currently acceptable definition. Altruism, this is another term when it comes to transplantation. So as the transplantation becomes more complicated, the definition of altruism, definition of assessment of underlying altruism ethics becomes more complicated. To give you an example, blood transfusion, it is also a blood donation. It's also a tissue which is given to another individual as a gift. When you look at a very simplistic way, because it doesn't involve retrieving an organ, it doesn't involve taking it from a cadaver, it doesn't involve many other complicated issues, it appears very simple, but it is also quite complicated in the sense, earlier, before I took up psychiatry, when I used to see people donating blood, I used to feel, oh, they have a great altruistic purpose. And later on, as you kept on seeing, there were only a couple of people who were repeatedly coming and giving blood. Then the question comes, is it altruism or something else? Then as you take up psychiatry and you know later, people who are abusing drugs, people who have certain personality disorders, people who have depression, what drives their altruism? So is it the money they want that day to deal with their withdrawal symptoms that pushes them to go to in search of blood banks and give blood and get some kind of monetary benefits? And what is this? Then as you go to the transplantation of cardiac or hepatic or renal, it becomes quite complicated. So I'll be using this word altruism in between during my talk. Next is the consent, which has been already talked to about various issues related to informed consent. What is informed, what is consent, how complicated it is, how much it is understood, is it really informed or coerced? The next is the voluntariness. So how voluntary it is, and on the face it may appear voluntary, but there may be other kind of factors which may push a person to give or receive an organ. Coercion, which may not be very apparent but needs to be evaluated in a very careful manner. Donor and recipient, these are the other terms which are commonly used. Donor and recipient. So I'll be talking more about my experience in evaluating ethical issues, evaluating the donor and their altruism, and then how to help the transplantation team. Then related donor and unrelated donor when it comes to the donor, or it can be a cadaveric donor. Quality of life, this is an important keyword, one has to keep it in mind: quality of life of the donor, quality of life of the recipient, and an ongoing quality of life, not cross-sectional. HOTA is Human Organ Transplantation Act 1994. This is the document which helps for the legal aspects of it. I will come to the details of that a little later. And demand and supply. This is a complicated equation. It leads to many problems in the transplantation. If the supply is less, demand is more, people try to circumvent some of the ethical issues. Milestones, if you look at the organ transplantation in 1902, E. Ullman, he first tried xenotransplantation in the dog. That was 1902. In 1912, Carroll, he first tried vascular suturing. He perfected it and got a Nobel Prize. 1945, Hufnell, Hume, Landsteiner, allograft. They tried to put a graft to the arm vessels and tried to establish that the tissue can function. So this was in 1945. In 1954, Murray, he is the one first who tried on identical twins and tried to show that this is possible. First living related donor was from mother to son. The son who met in an accident and damaged his kidney got the kidney from the mother. This happened in France. This was around 1950s. In 1959, the first concept of brain death got some kind of a consensus, and there are some kind of development related to that. What is brain death? So, a person who is dead but heart is beating, but a person who is dead and heart is not beating, that kind of a division in cadaveric donors. In 1960, the further developments in immune suppression, and these are the milestones which has led to the real advances in transplantation. Today, what is in the last 10 years, what is the greatest advance in the medical science? It's the transplantation. Like there is a lead article in New England Journal of Medicine where they have talked about a series of cases where women have got transplantation. After that, there were ethical issues related to whether they can become pregnant and deliver children, and they are on immune suppression. So, ethics does not end only in transplantation. Even after transplantation, their life and their decisions, who will decide? Will they allow, or if they allow, what happens to the kidney which is transplanted? So, there is an important article looking at a continuous ethical dilemmas for clinicians, not only pre or post or even later, as long as patient lives. So, these are the main milestones which has led to the real advances. So, we should continue to progress in advances in transplantation rather than some of the factors which try to act as the roadblocks in the developments. The notion of benefit, who is benefited by all these things? Is there any medical need? There is a person who has the problem and there is a real medical need. So, the clinicians have to assess this medical need. And time to death, does this intervention prolong the time to death? If so, then the procedure is worth it. But suppose the time to death it does not get prolonged, then is that transplantation worth it? There are issues like if there is a dialysis, which a person can afford dialysis, and if you can take care of all aspects of infections and other things, and then in another person with renal transplantation, in both time to death may be same. It is only the affordability. Particularly in a country like ours, people can't afford continuous hemodialysis or peritoneal dialysis and its complications. Renal transplantation becomes a choice. But does it really extend the time to death? This is another notion of benefit, one has to keep it in mind. Quality of life, like I already mentioned, there are various scales to assess quality of life. It is not just based on 2-3 questions, how are you feeling, or how as a donor you feel after giving the kidney. Even people have looked in research trying to see a donor who has given kidney 10 years back and has lived and has seen somebody else living, what is his psychological kind of state. People have come out with this, that there is some kind of a feeling of good in those people who have given and they have felt, I have gifted life. But there can be again very complicated issues as you go into this, Conflict resolution. So, the earlier points were to do with assessing the benefit, and then conflict resolution. So, as clinicians or even as a patient or researcher, we always come in conflict, but we should have methods to resolve this rather than say that there are conflicts and then don't do this. One is the consent, get a proper consent. So, try to understand the good methods of voluntary consent taking procedures, consent from the donor, consent from the family, and consent in a person who, even before he dies, whether he is willing to give the kidney. So, the consent at various levels. Advance directives, this is where do not resuscitate or willing to donate after death. So, trying to have this kind of systems which will help probably in taking consent easily, because what is important in cadaveric transplantation is early retrieval of the organ and get consent quickly and then help somebody else. So, that there are many barriers there, including the barriers from the religion, the society, the family, and various kind of things. So, developing a system of advanced directives may help in resolving the conflict. An expert team. So, one has to develop a team which will continue to audit and develop some kind of consensus in resolving the conflicts. It is impossible for only a surgeon or a nephrologist or a social work or a psychiatrist alone to resolve the conflict. So, there are many technical complicated issues related to organ transplantation. In principle, keep it in mind, equitable access. The problems where it comes up is where there are issues related to race, gender and economic issues, where people if the vulnerable group like mentally ill can be vulnerable, similarly certain racial, certain gender, particularly females in our country, and people who are poor in our country are vulnerable. So, we have to keep it in mind about equitable access. Risk, we have to keep it in mind, what is the risk to the individual, to the donor or the recipient versus benefit to the individual as well as the society or the family. And psychological acceptance. So, it can be a very temporarily, you cannot assess this in just 15-20 minutes. People may say, I have accepted it, I want to give, or I have accepted it, no problem. But then there are many other later in the literature issues which come up. For example, initially people may have anxiety, depression, then ambivalence, reluctance, and then they give. And after they give, the relationship between the donor recipient, what relationship they had earlier, what relationship it develops later, how it gets either become dependent or complicated, and more of resentment starts, thinking that why did I give to this person, and it is very, very complicated area. Like yesterday I was trying to go through some of the articles in which these kind of issues are discussed. Whereas, if you really check books on renal transplantation, surgical methods, the pages and pages are written about other complicated issues, about genetics, HLA match, renal disorders. When it comes to the psychological aspect, acceptance, resentment, willingness, and there are very few pages there, because again it is very complicated, and that area needs to be worked on further and document, and then see are there any differences across cultures, differences across various socio-demographic factors like education. And so, psychological acceptance also one has to keep it in mind. Unmanipulative in consenting, how indirectly, directly pharmaceutical or transplant team or relatives or other kind of people, how they manipulate in consenting. There should not be any deliberate distortion, omission of information in order to encourage acceptance. That may happen in day to day, even while prescribing a drug or trying to do a surgery. So, one has to remain unmanipulative throughout. Maybe once it may be possible, but then next time whether you are vulnerable to become manipulative, and then you change the decision. Open-mindedness in clinicians, because if we do not keep open-mindedness, we do not contribute for further advances in this field, and technological advances will not take place if we do not keep open mind and continue to work and resolve these ethical issues. Donor selection, I will be talking more live because I have more experience there. Cadaver, one of my colleague who is a psychiatric social worker, she has a lot of experience how she goes as soon as the death is declared, how she works with the family members, and then in a system where there is no earlier kind of a consent is given, how to work with them and how to get consent from the family members. So that is how the mental health professionals are involved in this. Although you ask why in transplant mental health people are involved, that is because of again improving agreement or assessing altruism properly, and these kind of issues. So, compliant patient. So, a donor also has to be compliant to whatever instructions post-op and understanding. So, a consenting donor should understand all the complications